Long-term outcome of endoscopic resection for intramucosal esophageal squamous cell cancer, a secondary analysis of the Japan Esophageal Cohort study. Introduction. Esophageal cancer was estimated in 2018 as being the 8th most commonly diagnosed cancer, with 572,000 new cases diagnosed annually worldwide, and as the 6th most common cause of cancer-related deaths, with 508,000 deaths recorded annually. Although the prognosis of patients with advanced stage disease remains poor, early-stage esophageal cancer is curable. The diagnosis rate of superficial esophageal squamous cell carcinoma, ESCC, has increased because of improved endoscopic diagnostic technologies, including chromoendoscopy with Lugol's iodine solution, image-enhanced endoscopy, and magnifying endoscopy. Endoscopic resection is accepted as a less invasive method for local resection of superficial ESCC, which carries a low risk of lymph node metastasis. The Japan Esophageal Society (JES) guidelines for diagnosis and treatment of carcinoma of the esophagus state that the absolute indications for endoscopic resection in cases of ESCC are lesions limited to the epithelium or lamina propria. Endoscopic resection can also be considered in some cases with tumors, relative indications, extending into the muscularis mucosa or the submucosa up to a depth of 200 micrometers or less beneath the muscularis mucosa, SM1. Conversely, endoscopic resection is not recommended for SM2 lesions, i.e., lesions invading the submucosa up to a depth of more than 200 micrometers beneath the muscularis mucosa, which are associated with a high frequency, approximately 40%, of lymph node metastasis. Several studies have reported favorable short and long-term outcomes of endoscopic resection for ESCC. However, all of these studies were single-center studies or retrospective studies. Oda et al. Recently conducted the Japan Esophageal Cohort study, JEC study, which was a multicenter prospective study performed to evaluate the cumulative incidence of metachronous ESCC following endoscopic resection. The aim of the present study was to determine the prospectively collected long-term outcomes of endoscopic resection for ESCC as a secondary analysis of the JEC study. Background. Prospectively collected long-term data from patients undergoing endoscopic resection for superficial esophageal squamous cell carcinoma, ESCC, are limited. The aim of this study was to determine the prospectively collected long-term outcomes of endoscopic resection for ESCC as a secondary analysis of the Japan Esophageal Cohort, JEC, study. Methods. Patients who underwent endoscopic resection of intramucosal ESCC at 16 institutions between September 2005 and May 2010 were enrolled in the JEC study. All patients underwent endoscopic examination with iodine staining at 3 and 6 months after resection and every 6 months thereafter. We investigated clinical courses after endoscopic resection, survival rates, and cumulative incidence of metachronous ESCC. Results. 330 patients, mean age 67.0 years, with 396 lesions, mean size 20.4 millimeters, were included in the analysis. Lesions were diagnosed as high-grade intraepithelial neoplasia in 17.4% and as squamous cell carcinoma in 82.6%, limited to epithelium in 28.4%, to lamina propria in 55.4%, and to muscularis mucosa in 16.2%. En-bloc resection was achieved in 291, 73.5%. The median follow-up period was 49.4 months. Local recurrences occurred in 13 patients, 3.9%, and were treated by endoscopic procedures. Lymph node metastasis occurred in 2 patients, 0.6%, after endoscopic resection. The 5-year overall disease-specific and metastasis-free survival rates were 95.1%, 99.1%, and 94.6% respectively. The 5-year cumulative incidence rate of metachronous ESCC was 25.7%. Conclusions. This study demonstrated that endoscopic resection is an effective treatment for intramucosal ESCC with favorable long-term outcomes.